Good morning, everyone who's joining. We're going to start in about a minute. Okay, well, listen, I'm going to start and kick us off here. So good morning, welcome to HIV Center Rounds. Happy New Year to everyone, and most importantly, a healthy new year to you and all of your loved ones. You know, it's been a challenging time. Hope you got to at least get a little bit of a break and quality time and a break from work over the holidays and some quality time with your friends and family. But we do wish everyone a very healthy going into the new year during these very challenging times. And thank you for being here. So let me do a quick announcement of upcoming rounds in February. On February 3rd, we have two of our former fellows coming to speak with us. Miguel Munoz-Laboy, talking about addressing chronic loneliness as a determinant of behavioral health for migrant youth and emerging adults. And Mike Stirrett, who, as you know, is now at NIMH, long-acting regimens for HIV prevention and treatment, a social behavioral research agenda. So that's February 3rd for Miguel and for Mike. And then on February 17th, we have well-known leader in the field, Monica Gandhi, and talking about HIV adherence and metrics in 2021, update about where we're at with HIV adherence metrics. So please join us those dates, February 3rd, February 17th. Okay, so today we're fortunate to have two presentations from current fellows, and I'll introduce them one by one. We have both Dr. Raymond Moody and Dr. Michael Vaughn. Ray Moody will go first, so I'm going to introduce him. We'll have his presentation. We'll have a brief question and answer discussion, and then we'll move on to Michael. So first up, as I said, is Dr. Raymond L. Moody, who is a T32 Substance Abuse Epidemiology Training Program postdoctoral research fellow, and that's in our Department of Epidemiology here at Mailman School of Public Health. Ray got his Ph.D. in clinical psychology from the Graduate Center of the University of New York and completed his psychology internship at the Ohio State University Wexner Medical Center. Ray's research examines the impact of social and psychological stress on substance use and sexual behavior among sexual and gender minorities. His current projects examine the impacts of substance use on sexual behavior and adherence to HIV prevention strategies in the context of intersecting stressors. So I turn the floor over to you now, Ray, and thank you for being here. Ray, you're on mute.
Sorry, the buttons just moved around whenever I...
There you go.
Yeah. Okay, now let's see. Can you see my slides again?
Yes, looks good.
Great. Well, thank you, Bob, and thank you for that introduction. Good morning, everyone, and I'm so happy that you're here. I think the last time I gave a Grand Rounds presentation was at the Ohio State University, and it was at the beginning of the pandemic, and I was presenting to an empty room with only the chair sitting in the very center of the room, staring at me without any sort of affective expression. So this is a little different. I mean, I can't see it in most of your faces, but I'll just assume that you're all smiling along with me. So yeah, I'm excited to present to you my talk, which is titled "The Role of Emotion Regulation in Maintaining Syndemic Burden Among Sexual Minority Men." And this is some of the research that stems from my from my dissertation. All right, so we're now 40 years into the HIV epidemic, and although the number of new HIV infections has decreased among gay and bisexual men in the United States over the past several years, approximately 70% of new infections in the US in 2019 occurred among gay and bisexual men. The Department of Health and Human Services has set the goal of reducing new HIV infections by 90% before 2030, and so we still have plenty of work to do. The HIV prevention toolkit continues to expand with the development of safe and effective pre-exposure prophylaxis, as well as advances in viral suppression treatments. But condomless anal sex in the absence of pre-exposure prophylaxis remains the most common method of HIV transmission among gay and bisexual men. It is estimated that only 25% of HIV negative gay and bisexual men are prescribed PrEP. So with this in mind, condom use remains an important strategy for HIV prevention, particularly among those who are not prescribed PrEP. So I'm interested in examining some of the factors that influence condom use and drive HIV transmission among gay and bisexual men. And what are some of these factors? By this point, I'm certain that we are all very familiar with the term epidemic, and we are exhausted by the term pandemic. But I would like to introduce a term that some people may be less familiar with, and that is syndemic. So what is a syndemic? A syndemic is defined as having three primary characteristics. First, two or more diseases that cluster together in a population. Second, observed biological, psychological, and social interactions between these diseases. And third, recognizable social determinants that contribute to the clustering of the diseases. Syndemic's research seeks to identify why these diseases cluster in a population, pathways through which diseases interact, and social conditions, such as social inequalities and injustices that contribute to disease clustering, disease interactions, and disease vulnerability in a specific population. This syndemic framework was applied in the mid-90s to AIDS research after it was observed that substance abuse, violence, and AIDS, or the SAVA syndemic, clustered among urban communities living in poverty. The results from this work demonstrated that these diseases were inextricably linked and mutually reinforcing, and really helped shift HIV and AIDS research away from examining epidemics individually to a more holistic approach that focused on understanding the interconnectedness of multiple diseases. Today, there exists a large and growing body of research that has applied the syndemic framework to identify clusters of diseases and other social factors, also referred to as syndemic conditions, that contribute to the vulnerability for HIV infection and HIV burden among gay and bisexual men. Some syndemic conditions that have been identified include childhood sexual abuse and intimate partner violence, depression, sexual compulsivity, and polydrug use. These different syndemic conditions have been observed to have high levels of comorbidity and to have an additive influence on HIV transmission risk among gay and bisexual men. Findings from this research suggest that HIV prevention interventions may be more effective in reducing HIV transmission risk if they targeted these syndemic conditions as a whole. So with that in mind, I became very interested in examining potential psychological processes that might cut across multiple syndemic conditions and could be potential targets of psychological interventions. However, the respective intervention literature has really mostly focused on select syndemic conditions rather than a more holistic approach aimed at reducing the overall syndemic burden. So as was mentioned, I'm a clinical psychologist. I'm also identified as a health psychologist. And so I'm very interested in identifying psychological vulnerabilities that impact health outcomes among sexual minority men. Among this, within these interests, I'm really interested in self-regulation, specifically attention and emotion regulation, and how these mechanisms influence HIV transmission risk, as well as substance use and other health behaviors. So what is emotion regulation and how does it impact health? It may be first helpful to review how our emotions affect us. And we know that emotions impact our physiology, they impact our cognitive perceptions, and they impact our behaviors. Emotions can really be helpful or unhelpful depending on the context. When they're unhelpful, they're like either the wrong intensity, wrong duration, wrong frequency, or wrong type for a particular situation. In these unhelpful situations, they can bias our perceptions and our cognitions, and they can bias our behavior maladaptively. For example, if you're on a Zoom meeting and you are feeling anxious about your presentation, you might look at somebody and you might look at the screen and see that people aren't, smiling the way that you would hope that they would, and think that you're not making a good impression. And this could lead you to say a little bit too much, or maybe even go out and, decompress in a way that's not so helpful after the presentation's over. But emotion regulation involves employing strategies that could change the magnitude or direction of this undesired or this less desirable emotion that you have in the situation to a more desirable emotion response. Just really focus my attention on the people that are smiling on the Zoom grid, just to reassure myself that I'm doing okay. So according to the process model of emotion regulation, there are a range of emotion regulation strategies. I won't go into these too much, but they're all depicted here in these blue arrows. And really involving the situation modification, management of attention, management of cognitions, as well as response modulation. Attention is something that I'm interested in because it's one of the earliest strategies that we develop and use to self-regulate our emotions and behaviors. When we're confronted with emotional stimuli that is in conflict with our emotional or behavioral goals, we employ executive functions focused on attention or executive attention to direct our attention to stimuli that is most salient for the goals that we want to achieve. So therefore, executive attention is an interest of mine just because it's so closely tied to emotion regulation. Overall, research suggests that difficulties with emotion regulation are associated with increased vulnerability for internalizing and externalizing psychopathology. And even some research suggests that emotion regulation difficulties may be associated with increased HIV transmission risk, albeit a lot of the research has been done involving heterosexual samples with less done with gay and bisexual men. So this brings me to the aims of my study and the hypotheses. And really it was just to examine the impacts of, or the influence of emotion regulation and executive attention on syndemic burden. That is the number of syndemic conditions present and the associations with syndemics and HIV transmission risk. And I hypothesized that syndemic burden over time would be mediated by emotion regulation and executive attention. And then difficulties with emotion regulation and difficulties with executive attention would be associated with increased HIV transmission risk via greater syndemic burden. So data for this study come from the project 1000 Strong, which was a cohort of HIV negative gay and bisexual men from across the United States. These men were over the 18 years of age or older, had recent sexual activity with a man, were able to complete a study, surveys in English, and were willing to complete at-home HIV and STI testing, and had a residential mailing address. This was required to be able to mail them HIV and STI tests at home, as well as residential stability, meaning they hadn't moved multiple times within the past few months. For the present study, I'm only focusing on men who are not on PrEP at the 36-month follow-up. And so this is 730 gay and bisexual men across the United States. Here's a demographic or a depiction of the demographics of the sample. The mean age of the sample is 40.33 years of age. And the sample predominantly identified as white and gay. A majority were full-time employed and had a 4-year college degree or more. Almost half had an income greater than $75,000. And a little more than half reported that they were in a relationship. Participants completed multiple assessment periods, and I'm focused on the 12-month, 24-month, and 36-month assessments. And we assessed syndemic conditions at 12 months and 36 months. Or for this study, I'm looking at syndemic assessments at 12 months and 36 months, including childhood sexual abuse, intimate partner violence, depression, sexual compulsivity, and polydrug use. And I assessed emotion regulation difficulties and executive attention at this 24-month assessment. So the assessment occurring between the other two assessments. For my analyses, I first calculated a syndemic burden variable, which was a count of the number of syndemic conditions present at each assessment point. So each of those measures were dichotomous indicators based off of established cutoffs or previously published variables. And I summed all of those consistent with some of the syndemic literature to create an overall count of the number of syndemic conditions present at each assessment point. Then I assessed 2 path models. In the first model, transmission risk, or the 2 models only differed in the sense of the way HIV transmission risk was treated. In the first model, I treated transmission risk behavior as a count variable, as a count outcome. In the second model, I included an offset, which treated HIV risk behavior as a probability. So in the first, we were just looking at the frequency of just the number of condomless anal sex acts with male casual partners. In the second outcome, it's really the probability, because we're looking at the frequency in the context of the number of just potential exposures. So the number of potential opportunities that they could have used a condom or not used a condom. So the number of anal sex acts. I adjusted all the models for age, sexual orientation, education, income, and relationship status. So here's a depiction of the prevalence of syndemic conditions at each assessment period. Childhood sexual abuse was only assessed at one time point because it wouldn't be expected to change over time in this adult sample. And as you can see, the most common condition reported was sexual compulsivity, followed by childhood sexual abuse, then intimate partner violence, depression, and the least reported syndemic condition was polydrug use in this sample. So here are the results for the first model that I ran. As you can see here, the syndemic burden at the 12-month assessment was associated with, was negatively associated with executive attention and positively associated with emotion regulation difficulties. This is consistent with my hypotheses that that basically syndemic burden would be associated with poor self-regulation. Syndemic burden also predicted syndemic burden at follow-up, unsurprisingly. And emotion regulation difficulties also had a direct association with syndemic burden at 36-month follow-up, but executive attention did not. In this model, interestingly, none of our variables that we examined were significantly associated with the count frequency of condomless anal sex acts with male casual partners. It's surprising given the existing syndemic literature showing that syndemic burden is associated with condomless anal sex. here's a table that shows the indirect effects, because we were looking at mediation, as well as the combined effects. So the overall direct plus indirect effects. Here you can see that the syndemic burden at the 12-month assessment was indirectly associated with the syndemic burden at the 36-month follow-up via emotion regulation difficulties. So this is consistent with my hypothesis that emotion regulation difficulties help explain some of the relationship with syndemic burden over time. Additionally, you can see that the syndemic burden, just the overall effect of syndemic burden at the 12-month on our syndemic and outcomes. And in this, when we look at the combined effects, we do see that syndemic burden at baseline, or at 12-month, sorry, I keep calling it baseline, but we're starting at the first assessment in this study, in these analyses, was positively associated with the number of condomless anal sex acts with male casual partners when we looked at the overall combined effect. In this second model, we wouldn't really expect any of the first part of the associations to change, just because we're only changing how we've treated our condomless anal sex outcome. And so as you can see, that treating it as a probability here in looking at these direct effects, after accounting for all other effects in the model, that still there were no significant direct associations on our probability outcome of condomless anal sex acts. However, when we look at the combined effects, we see that syndemic burden at the 12-month assessment were still associated with the probability of condomless anal sex during a given sex event. And emotion regulation difficulties also predicted the probability of condomless anal sex with male casual partners. So for those who experienced higher emotion regulation difficulties, they were more likely to not use a condom during a given anal sex act with the male casual partner. So what does this all mean? First, just to summarize, emotion regulation was affected by syndemic burden and also impacted syndemic burden at follow-up. This suggests that, and difficulties with emotion regulation were also associated with a higher probability of not using a condom during an anal sex act with a male casual partner. So this suggests that emotion regulations interventions may be needed and may be helpful in addressing the syndemic burden among gay and bisexual men and potentially reduce HIV transmission risk. Although executive attention didn't pan out as a significant mediator of syndemic burden, their research suggests that executive attention is an important factor in emotion regulation. So could be beneficial to address it as well, but in this sense, it may not be as meaningful as an independent target of syndemic interventions. So the limitations, so one of the limitations of this research, I think, is just the generalizability due to the sample composition. First, this is an HIV negative sample, and so we know that syndemic burden does not only affect HIV negative gay and bisexual men, that it may not generalize to HIV positive gay and bisexual men, but there is some great literature out there as well examining syndemics among HIV positive men. And then as you probably noticed in the demographic table, that there was some limited diversity in terms of racial and ethnic composition, education, and economic and income. And so I think additional research is warranted that using more diverse samples. And I know some of my colleagues, even the colleague on this call or on this, I think in attendance, is doing some of that follow-up work. Future research may also consider some additional factors or syndemic conditions and outcomes including things like suicide, as well as there's some really interesting work coming out right now looking at how COVID-19 interacts, is affecting gay and bisexual men in the context of this existing HIV syndemic. So it would be unsurprising if COVID-19 turned out to be a very important syndemic of its own, or a syndemic condition for this population. I think where I'm excited about to take this work is to focus more on the antecedents. When I was presenting this, the early versions of this to some of my mentors, the feedback that I got was, well, what about these social determinants? And one thing that I'm very interested in focusing on is the impact of intersectional stigma on syndemic burden, particularly with, in the context of HIV, substance use, and other forms of and forms of victimization. And so this will be the inspiration of my KO1 proposal that I, am currently working on, or this is the inspiration, I guess I could say, because I'm currently working on it. But yeah, I'm very excited to take this work and to apply it and focus more on social determinants. In general, I think the implications are that emotion regulation is an important factor for physical and mental health among gay and bisexual men, that adaptive emotion regulation skills may reduce syndemic burden and HIV transmission risk. And there are some existing emotion regulation interventions, some that I've worked on, that I've been inspired, that kind of inspired some of this work by John Pachenkis or Doug Menon, that focus on emotion regulation. And even John Pachenkis's group has adapted their emotion regulation intervention for gay and bisexual men experiencing different syndemic conditions. And I think these could be further adapted to really work with populations who have the highest level of syndemic burden. And as I mentioned, research is needed that examines the impact of these social determinants on emotion regulation, as well as the overall syndemic burden in this population. So I just want to thank my mentors on my dissertation, who have guided me for many years, and the entire team at Pride, where this research was conducted. Thank you to the National Institute on Drug Abuse for the funding of my R36, as well as the R01 parent study, and the participants, of course, who volunteered their time. And thank you very much.
Thanks so much, Ray. Cute dog.
Thanks.
Very cute dog. Thanks.
If anyone has any questions, please enter them in the chat or use the raise hand feature, and I'll unmute you. We have a question from Brian Kuttner. Brian asks, well, first he says, great talk, Ray. What do you think the role of executive functioning and emotion regulation might have in relation to engagement in PrEP, if any, given how low it is?
Yeah, that's a great question, Brian. And I think it's something that I've been thinking a lot about lately, because one of the things I've been struggling with is just how relevant condom use is as we move forward in our in HIV prevention, and like particularly as we move with the approval of long-acting injectable PrEP and things like that. And so and this, when I was really preparing for this talk, going back to some of just the basic epidemiological data and seeing how low PrEP uptake is, again, it reminds me that, that condoms remain an important strategy, likely for many people. But I think when we think about when I think about emotion regulation and executive functioning, I think, well, particularly like with emotion regulation, I think about how people navigate decisions for their like short, and the difference between like prioritizing short-term goals versus long-term goals. Emotional avoidance, or emotions influence motivation, especially. So emotional avoidance around stigma, I think, is a big factor, and may deter people from having conversations with their providers or with people that they know about PrEP. It may discourage them from taking PrEP with them because of PrEP stigma. And so I think that emotion regulation would help, having more access to adaptive emotion regulation skills in this context would help people navigate that stigma in a way that would allow them to either engage or to engage with PrEP in more regularly, whether that's by approaching their doctors, approaching their friends, or consistently taking their PrEP when they are prescribed PrEP. So I think I think about a lot of it in the sense of navigating that stigma, because we know just how impactful stigma can be on PrEP engagement.
Thanks, Ray. Michael, you can go ahead.
Ray, this talk was amazing. Thank you for sharing. I wanted to ask, because you just brought up stigma, I'm wondering, could you share a little bit about how you're thinking your K is going to bring intersectional stigma into this portfolio, into this kind of project?
Yeah, I think really related to what Brian just asked was that I'm focusing, there are a number of stigmas that gay and bisexual men experience that I think affect PrEP and HIV related behaviors. And so I think that it ballooned really, in my interest, and then I've had to, throughout my, thinking through my K, scaling it down some. So at this point, I really focusing on multi-level stigmas, stigma at multi-levels, but just really focusing right now on substance use stigma as well as sexual minority stress. So and how those may interact to prevent people from really engaging with HIV prevention, whether it's services or strategies themselves. So I think that I want to stick with the emotion regulation piece and just see how stigma affects emotion regulation, whether certain strategies are more effective or less effective in navigating those stigmas, and how other aspects may support emotion regulation, like, for example, social support and social networks, how those might impact the people's ability to employ adaptive emotion regulation strategies. So really right now it's just focusing on the intersection of substance use stigma as well as sexual minority stress, and how that might influence some of these outcomes that I've been talking about.
Ray, there's some comments. I'm not sure you're able to see. Christian Grove says, great job, Ray. He apologizes, he had to hop off. And Susan Traw says, thanks so much. This is such a welcome treatment of emotional variables in a field that is HIV prevention that has been so cognition heavy. And Karen McKinnon agrees with Susan, really welcome this line of thinking and research. I look forward to what you will learn.
Thank you.
Any other questions? Otherwise, Bob, I'll turn it back to you.
Okay, thanks. Thanks, Ray. That was really great. And I agree with those last comments about, getting emotions and regulation into our work around HIV prevention, because, as you're demonstrating, and we know it's not all it's not all cognitive, right? Emotions come into play with how we conduct our lives. So it's good to see this line of research. So thank you. Okay, so let's move on to our second presentation. I'll briefly introduce Michael Vaughn. So Dr. Michael Vaughn is a sociologist. He is currently chief fellow in our HIV Center's T32 postdoctoral training program. He got his Ph.D. in sociology from Emory University. Michael's research interests focus on the long-term impact of collective trauma on sexual minority populations, investigating the ways in which shared histories of medical trauma can continue to influence how subpopulations both understand and enact their sexual identity in the present day. Much of Dr. Vaughn's work focuses on the ways in which medicine and public health conceptualize sexuality and draw connections between sexual identity and illness. Pleased to turn it over to you, Michael. Thank you for being here.
Thank you. Thank y'all for having me. I'm so grateful to have this opportunity. I will share my slides and do the requisite. Can everyone see this?
Yep.
Yes, looks good.
Awesome. Thank you. So thank you all for joining. So the title of my talk is 3 Gay Generations, the ongoing impact of HIV/AIDS on meaning-making processes. And so just to give you a bit of a background, this is one of the core arguments for my current book project. So if you like this, if you're interested, keep an eye out for Ghosted, which hopefully we'll be making it to review with a few different publishers in the next year. Because this is a portion of a book project, and because I'm drawing a lot of my training in sociology, what I'm going to be presenting today is in a lot of ways a theoretical framework to understand the way that trauma continues to impact populations. So I will be, I hope y'all enjoy the ride for this little bit different presentation than we typically see at rounds. So my objective today is to articulate some of the ways in which the ongoing history of pathologizing queerness via medicine and public health influence identity processes for contemporary gay men. So in short, how does the past continue to matter in the present? And so how I'm going to talk through this portion of my book today is I'll start with my theoretical framework, which is drawing heavily on women's studies, queer theory, sociology, and some public health theory. Then I'll talk through my methods. Then I'll present 2 sections of findings, one on my archival research, which is focused heavily on medical archives. And then I'll close with my qualitative findings to show how all of this impacts the present day life of many gay men. For my theoretical framework, I use the phrase meaning making in my title, and I know that every single discipline uses some concept of meaning, and that word, it's redundant to say, but meaning often, quote, means something different across disciplines. So when I say meaning making, what I'm talking about is an active process where individuals are creating a shared understanding of some social phenomenon. And so that might mean, how do we figure out what it means to be gay? How do you define what it means to be gay? Individuals always have a working definition in their heads. Sometimes it's not conscious, but we always have one. How does that come to be, and how does that process keep moving? So the goal of this study was to better understand how collective medical trauma influences the meaning of gay identity. And I'll talk more about what I mean by collective medical trauma in just a second. To get at this framework, I use 2 core theories, one that's more in a cultural studies world and one that's more in a psychological world. The first is the concept of collective memory. If I needed to say something pithy and short, I would say collective memory is the notion that groups remember together. Oftentimes when we talk about memory, we think psychological, we think individual, we think neurological, we think cognitive. Collective memory is encouraging us to think a little bit more broadly. Group members often feel like they have shared experiences. And so the examples that folks often give are individuals who went to public school in the United States will often have a sense of what George Washington was like. And a lot of this is nationalist propaganda that has been fed into our public school system, but also we experience it as if we know it in some deep way, folks that did grow up living in the United States and going to public schools. These are collective memories that create cohesion among folks within the same group. In that case, it's American. So what I'm saying is I'm taking this concept of, I may have not lived through an event, but I feel like I remember it and I experience it as if it's a memory. And it's the same kind of experience that lots of other people who are similar to me feel. My question was, what about an ambiguous, a highly dispersed group like a sexuality? Can they have a collective memory? Some of the research says yes. Some of the research says that that's not a very interesting question. I'm more in the camp that says it is an interesting question. And through my book project, I show that gay men do have a collective memory. And so this topic becomes helpful when we think about what happens when there is a high impact event, like an epidemic or like maltreatment within a medical system. How does that become a shared experience for a group of people, even when every single person did not directly impact it? So not every single person was mistreated by a medical provider or received a certain diagnosis. But if an experience is common enough, it feels like everyone, quote unquote, knows about it. So this is a collective memory. So this is the broad framework that I'm using to understand trauma. The other half of this framework is identity theory, which is coming from social psychology. Put briefly, individuals are performing who they are during their interactions. So the identities that we hold, the roles that we hold, all come to bear in some way, shape, or form when we interact with others, particularly when that identity is relevant to the conversation, to the interaction. This theory is helpful because we have an idea of who we are and in some way impacts the way we interact with others and express ourselves throughout the world. To make this a little bit more concrete, the gay men who I interviewed had an idea of what it means to be gay, and that idea in some way impacted the way that they act in the world around them. My big argument for this project is that collective memory and identity theory in some ways come together. And so the way that we understand our group's shared past will impact the way that we understand who we are as a group member and therefore influence behavior. Taking that formulation together, this led me to the question that's going to lead the rest of this presentation. How does the memory of medical trauma influence the meaning of an identity for the affected population? And then what's the downstream influence on identity-related behavior? When I use the word trauma, I'm not referring to individual experiences of trauma, but rather a high impact, emotionally laden event that impacted a population or a subpopulation. So a collective trauma rather than an individual trauma. And for brevity, I will often refer to this just as trauma, but I'm referring to collective trauma in these situations. How did I do this though? And so the empiricist in me loved these ideas and I was like, okay, but how do we concretize it? How do we make it a thing that we can actually analyze and study? And so I broke this down into two kinds of methods, which are on the left and right hand of your screen. On the left side, you'll see my archival research. Archival research entails identifying primary and secondary documents. So documents, primary meaning documents that were created by people who experienced something or directly capture an event that was experienced. And secondary is someone recounting an event that was told to another. So you can think of it as like, I learned this, or I'm summarizing things that other people have learned. Using primary and secondary documents, I consulted the Stuart A. Rose Library, Yale University Archives, and the Schoenberg Center for Research in Black Culture, which is housed within the New York Public Library. I selected these three archives because they had robust and highly diverse collections of documents related to LGBT life, related to HIV, and related to AIDS activism, and medicine more broadly. To give you a sense, because I know most folks have never been in an archive, I'm going to assume. These documents include things like letters that folks wrote each other, which were donated to the archive, memos from APA meetings, diaries of clinicians who were treating HIV patients in the 80s, medical textbooks or diagnostic criteria, flyers from pride events or protests, posters denoting that an event was going to happen. In a lot of ways, archival research uses the mundane to help get a sense of what was life like in this moment and what were the conflicting narratives that we often don't remember once that moment has passed. And to analyze this, you do this the way you would most qualitative data. I use a thematic iterative coding process. So if you look on the right side of the screen, now I'm going to talk about my in-depth interviews, which were 61 semi-structured interviews with self-identified gay men, all 21 years and older, who lived in the Metro New York area. So my archival data is referring to the United States writ large. My interview data then narrows down focus to just the Metro New York area. These interviews lasted between 1.5 and 2 hours. And the focus of the interviews were gay identity, history related to gay life, the individual sense of community within New York, and the individual sexual health. These interviews were all conducted in English, and I analyzed them using an abductive iterative coding process. I present this slide intentionally with the left and right side because my archival research and my interview research are directly tied, and the analysis goes back and forth between the two. As I learned more from the archives about the history of medicalization of homosexuality, which we're going to get to in a few minutes, they would influence the way that I would analyze my interview data and back and forth. So the first thing I want to start with is a little bit of a history lesson. And for many folks, this is context, and it might be a context that you're well aware of, but I want to talk through this anyway because it does undergird the rest of my argument. The first archival finding is that homosexual itself starts as a diagnostic term. And I want to share this story because it does frame the way that my qualitative interviews, or my analysis of my qualitative interviews. The earliest documentation of the term homosexual is in the 1860s in Germany, amongst a series of activists who were fighting against anti-sodomy legislation. Carl Maria Kurt Benny is one of the few activists who actually put their name on these documents because sodomy was so heavily sanctioned, both socially and legally, that most activists tended to keep their names and faces out of anything related to this. So Kurt Benny is one of the few who we can actually attribute this to. So Kurt Benny and colleagues created numerous pamphlets and written documents to talk about the normal variation of sexuality. And they created a series of terms. The two that tended to stick around, which I'll explain more how they stuck around, were heterosexual and homosexual. So I want to start with these two terms, which we often think of in terms of science and medicine, were created by social activists to fight against anti-queer, anti-sodomy legislation in Germany. In the 1880s, these terms got particular notoriety because Krafft Ebing drafted this book, Psychopathia Sexualis, which is still around in public health training today, often as an example of a complicated history related to psychoanalysis, but still is a part of our canon in many ways. Krafft Ebing appropriated Kurt Benny's terms and claimed them as his own, and used homosexuality in particular as a mental health disorder. And so from the 1860s to the 1880s, we see a shift of this term as initially meant to be normal variation and then becomes medicalized. It's literally used as a diagnostic criteria or as a sign of illness. Psychopathia Sexualis, as many of you know, is a book that is still being talked about today, still being read today in many cases. This book took off and in a lot of ways helped the psychological sciences become psychiatry, and it helped German psychoanalysis influence mental health care across the Western medical field. We see that impact continue into the United States and across the various editions of the DSM as well. We see homosexuality continue to be a diagnostic criteria, with the first DSM being in 1952. And then homosexuality as a term was not removed from diagnostic criteria or the index until 1987, DSM-3R. DSM-3 does have a change in how homosexuality is discussed, but it is still listed as part of diagnostic criteria in some way. It wasn't until 87 that that term was completely removed. I put this up here. Again, I know the audience I'm speaking to, many folks are very familiar with the DSM, but I think it's important to note from 1880 to 1980, we see just about 100 years of homosexuality being a mental illness. And I want to sit with that 100 years as I continue on. Around the 1980s, as there's this discussion of should homosexuality be a diagnostic criteria? Should it even be in the DSM? Is it a mental health thing? What is it? This debate is raging. As we all know, the HIV and AIDS epidemic starts in the United States, being officially commemorated in 81. The overlap of early HIV and AIDS discourse, particularly around the CDC using labels like GRID, underscores the fact that Krafft Ebing's work in the 1880s continues to have an impact because we still are pairing homosexuality and illness in some way, shape, or form, even as the APA is revising the DSM and actively working to undo some of the medicalization they have done in the past, we're seeing that it's still already laid its claws is the word I want to use, into the way we think about sexuality, particularly homosexuality. This, of course, contributes directly to stigma related that sexual minority individuals experience. And all of this lays to bear on how people experience their sexuality today. And so for the sake of time, I'm not going to go through quotes. I'm going to talk more generally, so I have time to continue through everything. But one of my key qualitative findings here is that when my participants were talking about their sexuality, and these are contemporary gay men aged 21 to the oldest being in their early 70s, consistently participants talked about their sexuality through what I call a plague bearer frame, which I picked this term pre-COVID, and it carries a little bit of a different tone right now, but I still think it's a useful, it evokes some kind of feeling in me and in others I found in the past. So I think it is still a useful term, even if it does feel strange in our current pandemic moment. I say plague bearer because my participants would often say, when asked if they could talk about what does it mean to be gay, how would they describe it, how would you define it, folks would say, okay, I'll tell you what it means to be gay, but first you need to understand, first you need to know about. And as a cultural sociologist and as someone who's deep in collective memory, anytime there's a historical narrative you need to know first to understand what it means to be something, that means that's a collective memory, because that is a key historical event, or a key story, a key narrative that the group sees as important to understand who they are. For the vast majority of my participants, this was some medical thing. Typically, it was some medical thing that was framed by the participant as self-imposed, transmissible, and untreatable. So gay identity became this thing that participants would say, I've done to myself, I can't change it, and like I could harm someone else with it. And again, this is all in a pre-COVID world that we're having this conversation. But these narratives mirror heavily the language that we saw in the early days of the HIV epidemic. Once we had an idea of what the virus was, this like, I did this to me, it's here forever, and like I could harm someone else with it. The it, of course, being who they are, one of their core identities. I don't want to say that every gay man I spoke to said the same thing, though. That is patently untrue. While participants generally relied on this frame, this idea of like gay identity being a plague bearer type thing, or plague bearer being a useful frame to talk about gay identity, the meaning ascribed to gay identity, or the way that they colored in those lines, might be another way to say it, it varied based on the individual's lived experience at the intersection of medicine and sexuality. So while all of my participants had this frame, this coloring book outline of a plague bearer when describing gay identity, how they actually gave it life, how they colored it in varied based on their own lived experiences. And I'm going to sit in this table for a little while, just because I want to talk through it. This is where my 3 gay generations comes in. When I say generation, folks can interpret that in many different ways. I'm relying on how Mannheim defines a generation, in that it's a collection of individuals all have a shared experience that for them unite them and mark them as similar to each other and different from others. Typically, when we talk about generations, we think Gen X, Gen Y, Gen Z, boomers, the greatest generation, we think in terms of birth cohorts. It might be helpful then for this conversation to shift the focus and think what actually unites a generation together. It's not the fact that they were all born around times with each other, but it's that they all were in their early adolescence or late adolescence or early adulthood, experienced something that united them all together. We would call that a generational imprint. And so thinking on a national scale, events like 9/11 or Pearl Harbor are often framed as generational imprints, where if you were a certain age when this experience, you're in that developmental moment, it shaped the way that you understand what it means to be a part of being American. I take this concept, which we've already used for broader identities like nationality, and bring it into sexuality. And so my argument is that we can think about the meaning of an identity both in terms of the shared experience that group has had, but also the history of trauma that they have incurred. And so let me concretize that for you. My oldest generation of gay men were folks who were growing up, so they were adolescents or early adults during a time when queer visibility was just starting to pick up in the United States. And they experienced collective medical trauma of psychological disorder. And what I mean by that is they were faced with the concern that if others learned about their sexuality, if they learned that they were gay, they would be diagnosed with a personality disorder, or they would receive some kind of diagnosis and forced treatment, or they would suffer these intense social sanctions related to this mental health component of homosexuality as medicalized. And so there's this tension here between their lived experience and their collective memory. When this generation talked about HIV, or when I asked them about it, they would often talk about the HIV epidemic as an interruption to gay life, because they had had the opportunity to experience gay life as a young adult before the epidemic began, and before the mortality rate spiked, and before they just can remember a quote unquote before. And so this was not formative for them, but rather HIV was an interruption, which is now something that is managed. The phrase interruption is key there, because many of the folks that I would talk to say, like, oh yeah, it's not like it used to be, so it is quote unquote better. This middle generation of gay men would often talk about grid. That was like the sticking point for many of them. They would talk about how CDC was often the person that they would point to, or the institution they would point to and say, they did this, look, CDC called it grid and they made it a gay cancer and they did this. So this medical component is completely public health related. And they're saying this generation was that we lived through that and we're still dealing with that, where doctors all think that gay is an illness and they think we're all going to get AIDS and die. These highly stigmatized experiences are defining what it means to be gay. And if I'm going to understand what it means to be gay for someone in this middle generation who's in their 30 somethings at this point, they would say, you got to understand grid if you're going to understand what it means to be gay. And the lived experience that I've paired with that was this idea of, when I was in high school, I was sure I was going to die, or I knew that being gay meant the certainty of death because HIV was a death sentence in 1985. So this is the thing that solidified it for me. And then the parallel to that was this idea that there are no gay elders. There are gay elders that exist in the world, obviously. I mean, I interviewed a portion of them, they're the oldest generation, they exist, but this feeling of I am the gay elder in my 30s, there's no one older than me, there's no one who can be like the wise additional person to support us as we learn. I have to figure it out because I'm the first. And feeling unequipped to do that given their age and their lack of connection to the community that came before them. So for this middle generation, when they think about HIV, they're talking about this is integral to gay life. Like HIV is defining gay life for us. And then I interviewed the youngest generation who are in their early to mid 20s. These folks, some of them may still be developing a generational imprint, but the narrative that continued to circulate across these youngest folks was resisting this quote unquote tragic gay collective memory. Many of these folks would talk about HIV as a more chronic condition. So it was a common comparison of saying, oh, it's like diabetes. It's a thing that could be really bad, but you can manage it. Like it's not, it didn't carry the same sense of fear and dread as this middle generation, where they describe a certainty of death. This youngest generation is resisting those stories and saying that, yeah, all of these quote unquote olds are telling me everything about how being gay is hard, being gay is sad, but I don't hear that. I don't see that in the same way. Instead, these folks, this youngest generation often shifted their focus. They were saying that the stories, the narratives, the memories that are being put on them are ill-fitting of their current experiences, and instead shift their focus more intersectionally and talk about the ways in which race and class are impacting quality of life, or how trans folks experience disproportionate amounts of violence. I mean, any violence is unacceptable, but trans folks are disproportionately impacted compared to cis folks. This youngest generation instead is saying like, yeah, the gay stuff is important, but it's not like, that's not the main story. You're actually looking in the wrong direction. And they would redirect me as the interviewer and it's like, you need to focus instead on that, not this. Like that, this gay thing doesn't necessarily carry the most weight. And this is still a generation that is, and I would wager that COVID will directly impact the way that they imprint, but I would imagine this youngest gay generation is going to continue to resist the narrow defining of gay identity around a medical trauma and instead continue to lead into this intersectional focus, which I have theories about, but again, they're still imprinting. So this is something that this generation will continue to figure out on its own. To wrap this up and to provide a little bit more of a general theoretical statement, identity groups may self-define based on their shared histories, particularly shared traumatic histories. So these shared trauma can help an identity group understand who they are. However, because traumatic events change over time, subpopulations may develop a shared sense of self and cohere into distinct generations, which is how we'll have a generation of gay men, a generation of lesbians, generation of whomever, could be anything. And each of these generations has their own definition of what it means to be themselves. This creates in-group differences. In my population alone, a 65-year-old gay man and 21-year-old gay man define being gay very differently. And as such, we're creating some in-group divides. And this could, in some ways, be fueling, in the New York City area in particular, the focus on youth culture and the focus on the gay scene being very youth-focused. If we have a different core definition of who we are, how do we coexist on the same scene? And so this may be exacerbating some of the already existing focus on youth and young people. For gay men, medical trauma influences perception of their gay identity, creating generational differences in what it means to be gay. I've been talking around that, but I want to just flatly say it, that medical trauma is one of the influences that change this. And thank you. That's the end of my presentation.
Thanks, Michael. A reminder to everyone, if you have any questions, you can enter them in the chat or use the raise hand feature. Teo, you can go ahead.
Thanks, Michael. Fascinating. It's always nice to hear you talk. I was curious if you could speculate for us what the differences are between these three generations in terms of how they think about sex and relationships. Or doesn't that distinction in these three generations matter at all?
So in terms of sex, I would think my oldest generation, which are all, again, folks who were adolescents or young adults before the 1980s, we'll say, before the start of the spike of the HIV/AIDS epidemic, folks often talked a return to before. And for some, it was a desire for a return, and for others, it was an actual return. And when I say return, I'm thinking the United States in the 1970s, this focus on love and sex and enjoyment and pleasure, and yes, an acknowledgement that STIs exist, but also this is not the primary focus. The focus was building connections through the physical and through the sexual. This was like one way that communities were developed. So this oldest generation did talk about that. There's a challenge, though, of that it being a dominant way to develop connections through the sexual, and the thing I alluded to for the youth culture piece, where a lot of these scenes have changed, where there's not necessarily public sexual encounters in Central Park in the way there were in the 70s, as one example. A lot of clubs and bathhouse people, I mean, all the bathhouses being shuttered in the 80s was one moment of, I lost spaces where I could do that together. And so this oldest generation, which is not very, I mean, they're trying to do math right now. 55 plus, I would say. This is not like an elderly population, but in many ways they're experiencing, they have a cognitive return to the before, but the lived experience, those spaces aren't there. And the spaces that do exist are so heavily youth focused that they're not necessarily welcoming to them. And so I saw a lot of my oldest generation talk extensively about just the loss of a social network, and not in the typical aging where our social networks condense. This was, I can't go and do the things that gay people do because they don't even exist anymore. There are no gay bookstores, there are no gay this, there are no gay that, like the actual, so changes in the built environment created a disconnect between the cognitive and sexual and the lived experience. I think that's the most stark answer to that. For the middle generation, folks would often talk about their sexual encounters as being, HIV was always a part of it, always a thing they're thinking of. Most of the middle generation that I talked to described as something that they do think about and they are conscious of. And I was not coming to them as a public health person, not coming to them as a medical person. I was a queer dude in a pair of Converses who wanted to chat about their sex lives. Like that's how they saw me. And many of them did say, like, yes, that's what I think about. And so fear of HIV in particular did guide how many of them talked about their sexual encounters. And in some ways did talk about how they would lean more towards closed relationship monogamy in a way that the oldest and the youngest generation did not discuss. For the youngest generation, so folks who are in their early to mid 20s, there was less of that kind of conversation. It tended to be more just redirecting away from gay. The idea of let's talk about gay identity was just less important. I think part of that is it developmentally makes sense that folks are not in their early 20s thinking about they haven't hit their quarter life crisis yet for many of these folks. So they haven't had that moment of reckoning with an existential dread. It might be I'm finishing finals in school. It might be I need to find a job and there's a terrible economy happening. There were other more proximal things that they were focused on. The biggest sex discussion where actually multiple participants talked about keeping a little black book of recounting all of their sexual encounters. And it was just the discussion of the discrete was much more important than the long term. And so this oldest generation was talking about the kind of sexual culture that they loved and the things they were valuing and missing. My youngest generation was much more focused on, oh yeah, last week this happened, or like, oh, let me take out my phone for you and I'll scroll and show you my like little black book of, I had one participant in particular who after every encounter keeps a document. He has like 10 things that he writes a thing about. And it's like, this was the person's age, this is what I liked, this is what I didn't like, this is what we did, this is how we did it, this is when we did it. And I was like, I want that for research, but I also want, like, it brought him joy. And he as one person kind of typified that generation for me of a focus on the discrete rather than the pattern across. Does that kind of get what you're asking?
Yep.
Awesome.
We have a question from Brian.
Hello, am I?
Hey, Brian.
Yep.
Soundable? Hearable?
Yes.
Unsurprisingly, I was going to ask the same question that Teo asked, but I have a different one now. That was really, really fascinating. And in part, it's really fascinating because I can easily identify myself sort of in that middle generation, like lean in sort of the liminal stage between that middle one and the more recent one. So it's really interesting to be able to see how the theory leads to the method, leads to the data and the findings. And I could also imagine how you could apply this to lots of other kinds of collective trauma, like related to racism, related to immigration, gender identity, how these things have changed over time. And I was curious, like I've never done archival work before, so I was curious, could you just spell out a little bit more the dialogue between the archival and the and the interviews, and like how you do that?
Yes. The first thing I want to say is, because you brought it up, a good portion of the collective memory research has its roots in studying the ongoing impact of racism. And I don't want to erase that. Much of my theorizing is indebted to that work, particularly the folks' comfort and discomfort around seeking medical support, given the long history of racism within medicine. So thank you for acknowledging that. Yes. It's not easy, the archival interview part. It takes, so I spent no less than 1 month in each archive, meaning like going 4 or 5 days a week, consulting documents. I would say that I read tens of thousands of documents conservatively. It's just, it is a lot of digging and a lot of, because so you can think of an archive as a repository. It's a place where if someone wants to donate something, they can just give it. And so that might mean that someone's great uncle is moving to Orlando and wants to just get rid of the house, and like, kids, figure it out. And you just put everything that your great uncle had, you just give it to Emory University Archives. And then they sort through and they document as best they can. The challenge for you is then you'll receive 5 boxes in the archive, and you have to just look through them. It's like, what's there? Because not every single letter will be separately identified. And the archivists are keeping track of the items, not necessarily the theoretical arguments being made in those items. So it is a lot of, whereas with interviewing, we can tend to be a little bit more precise. With archival, you have to give yourself much wider berth and just know that you're going to go through a lot of things that are amiss until you find something that's relevant. I can give a specific example though. These are all public documents, so I can share this. So there's a long-time HIV care provider. He's a gay man who's still alive, lives in Atlanta. He donated a series of his diaries. His name's Dr. Jesse Peel. He's recently published them as a book, P-E-E-L, like peeling a potato. Brilliant, wonderful human. He definitely doesn't remember me, but I met him years ago. He donated his diaries, which recount just his life, but it was his life living as an openly gay man and as a psychiatrist in the 1980s. And so finding his diaries was helpful for me because I was in the middle of my interviews and I couldn't quite understand the experiences of some of my oldest population. I couldn't grasp the idea of the epidemic as an interruption. That seemed strange to me because it's still ongoing. I was like, how can it be an interruption if it's an interruption forever? So reading his diaries, and particularly reading stories of him processing cases, and then the next day going to a nude beach, and then the next day going to a medical conference, and just like seeing how he laid out his life in this diary format, which is just, it was like, he had a pencil and a notebook in the car and he was writing. This was not like a formal thing. Seeing the pattern in how he laid out his story helped me better understand, and then go back to some of my transcripts, some of my interview recordings, and re-listen and look for a new theme, which I didn't know was there. So it's one example. Another would be that I found an archive of a printing press, and they did posters, and they posted for everything. But I was like, oh, did they ever do a Pride poster? And I looked at the Pride posters, and thankfully the archive had it 1980, when did they print 81, did they print 79, what did they print? And just seeing how every year the visual imagery on the posters changed. And if I could lay them out side by side, I could see how the way that we were visualizing the idea of gay pride changes over time. And I think what happens if the first time you went to Pride was in 1980, and then for the next 10 years, all you see are AIDS things, you're going to associate Pride and AIDS in a way that if I went to the first Pride ever, the imagery was very different. It was like fight back, it was protest, it was like, get the police out of our bars. There were just like different narratives. And so I hate to say that inspiration strikes, there is like a level of creativity in all science. And I think this was just one of those. The archival data would sometimes just be a different perspective to see narratives played out. And then I would go back to the interview transcripts and say, okay, well, did anyone say anything like this, or is this completely different? Or conversely, if I ever was like, okay, I think my youngest generation is saying that none of this matters. Am I seeing that? And then I would look at like magazines and photo shoots from the 2000s, like, okay, what were these kids seeing at this point? Like, how did that impact them? I think that's the quick and dirty answer to your question, Brian.
Thank you. It's really fascinating. I can't wait to read the book.
Me too.
Thanks, Brian. We have a question from Phil.
Hey, yeah, wonderful presentation. And appreciate seeing the way you describe the qualitative work and hearing about that especially. I guess I have two questions. They're both broad, so you can take them as you will. One is just, you mentioned drawing off race theory and just thinking about, as you look in these generations, and maybe you're working towards that. And you said a little bit about it, but I wonder about like differences in terms of within race and ethnicity groups or between, and also like thinking about socioeconomic status, like people have the means to sort of move in different echelons of society might be impacted differently in these eras. And then the other really broad question I have, and you started talking about COVID, it's just thinking about, clearly COVID affects all of us, but wondering how what you've learned from your research could inform how we think about how the current pandemic is going to impact identity development.
I love it. I think about this stuff like hourly. So yes. So to your first part about how race and class might impact this generational argument, it totally does. For my oldest and middle generation, oftentimes, regardless of race, folks would use these same key markers of mental health and then HIV as the sticking point to understand being gay. For my oldest generation, oftentimes how do I say this? The way in which the narrative was delivered would be racialized. And what I mean by that is, that's true of the oldest and middle generation, I will say that. So for my oldest generation, folks would talk about this emerging visibility being really important in the face of psychiatry being a force that could potentially really harm gay people. I had one Black participant in particular. He was in his late 60s, and he talked about how revolutionary it is that pose exists now. And for him, he found that media that featured Black queer people was the most important thing that I needed to put in this book. And he was like, if there's anything you write, it needs to be that matters more than anything. And for him, he talked about how emerging visibility was really important in his youth, but it was all white gays, with the exception of Sylvester. And then so he would identify particular queer people of color as, and Sylvester was the one that he stuck on because he was a DJ back in the day. So he I can't remember if he knew Sylvester or he knew someone who knew him, but either way, for him, he would say, yeah, there was like one person we could look to and be like, oh, that person's like us. And now that he's seeing shows on television that are accessible to many people, that have lots of queer people of color, for him, in some ways, it's similar to what I was saying before with Teo, how HIV was in some ways an interruption. Yes, there was a great loss. For him, one of the great losses was the death of disco, or disco is dead. But the idea of emerging visibility for white participants was like, oh, gay people are visible. And then for my participants of color, it typically was gay people were visible. How many of them looked like me? And you took what you could get, was often the narrative that we would get. And then like this one participant in particular highlighted more the importance of visibility of Black queer people. So it doesn't change the like generational sticking point, but it is an important piece of flavor behind it. And we see that difference get exacerbated in the youngest generation, where if gay is not a sticking point for everyone because there's no perceived uniformly shared medical trauma, which is partly, I would imagine, due to decrease in diagnoses among white gay men since the advent of PrEP. I would imagine since that's happened, this has become a little bit less sticky generally, because the media talks about it in different ways because of a million reasons. So that's the short version of the race piece. Class was something that was a little bit harder to identify. Folks would often not really talk about their resources. I had a few sorry, I'm like processing as I'm thinking. In my youngest generation, I saw the most variation among class, I would say, and it went from like homeless youth who talked about using sex work as a way to survive, youth meaning 21 and over. But from that all the way to Ivy League private school kids with two parents who are professionals, apartment on the Upper East Side. So I think there was a high degree of variation in terms of class there. And for this youngest generation, I didn't necessarily see differences in perception of gay identity, so much so as like the spaces in which it's enacted. So it might mean at a club, at school, in a sexual encounter, whether that's paid or unpaid. I think that was the biggest variation. The grim reality of class for my oldest generation is that the people I talked to all did have some source of income. They did have some sort of like medical support, because many of the folks who didn't died, it seems like, which is just a limitation of doing this kind of research. There's always going to be a sampling bias in my oldest generation. But yeah, I don't know that I necessarily have a much more precise answer than that. Phil, does that kind of get at your first question?
Yeah, no, I mean, I just more of something to continue to think about as you're doing this work. But yeah, definitely begins to answer it or speak to it.
Yeah, you're right. I do need to dig more into the class piece in particular. I think that's something I'm going to remember. Thank you. And so to your second part about COVID, I can like share an anecdote that I think is helpful. So I defended my dissertation in May 2020, which was like the pandemic was just beginning. We were all in lockdown. Like I think I was the first remote dissertation that Emory's done, which was like cool, but also it's a weird like honor to have of like the first defense being remote. But that was one of the questions that folks were asking me is because a good portion of my interest is when CDC called HIV grid, they like started a new vein of stigma, and they built on things that were already there, but they created another narrative that long outlives their use of the designation. And this was around the time that the former administration was making incredibly racist comments about Asian Americans related to COVID. And that was honestly most of my defense was conversations around that of like, how are these like racist moments going to continue to persist? And I mean, we've seen that they are. So I think all of the social bad that's happened around COVID in terms of identifying a lack of widespread support for public health, a lack of the rampant anti-intellectualism and like the feeling that science might not necessarily be a reliable source for support, notions of individualism being quote unquote the only way to handle situations. I think that that's all going to keep rearing its head, like it has been since the start of this nation, but I think it will continue. In terms of identity development, I think that the young folks now, so I'm thinking particularly like adolescents, so people who are in high school or maybe just starting college, maybe just graduated high school, whatever they are in their universe, those are the folks who COVID is going to be, in cultural social, we call it a generational imprint. And so it's the shared experience that you have from late adolescence to early adulthood. And it's if it's a high impact experience, it'll mush in some ways, and just help cement how you see the world around you. I think that no matter what happens with this pandemic over the coming years, the experiences over the last 2 years are going to impact identity development broadly. I don't foresee it interacting with gay medical trauma, given that many of the gay youth that I interviewed didn't see that as the important thing. It was like I was the old man missing the point interviewing them. They're like, why do you care about that? That doesn't matter. Instead, you talk about intersectionality, and you talk about race and transphobia, like those are the other things they're focused on. I think this medical experience might galvanize them to ramp up those views even more. That's kind of my hope, that it sparks the next generation to continue to do some of this work. I don't necessarily imagine it impacting gay identity per se, but I also am expecting that over the generations, like clinging to some sexuality labels will become less integral to how queer people understand who they are. That's my expectation for the future generation. So I don't think this will hook that I may be wrong, but that's kind of my crystal balling it.
Great, thank you. Yeah, really interesting to hear you hypothesize about how this will develop going forward.
Thank you.
Thanks, Phil, for your questions, and everyone that shared their questions today. And thank you, Michael and Ray, for your presentations. We're coming to a close, so Bob, I'll turn it back to you.
Okay, thank you, Stephen. And thank you, Michael. That was also a very stimulating, I think both very interesting and thought-provoking presentations today. So thank you both. Take care, everyone. Take care of yourselves, be healthy, and hope to see you on February 3rd for our next grand rounds with our two former fellows, Miguel Munoz-Luboy and Michael Stirrett. Take care, be well, Happy New Year to everyone. Bye-bye.